Hello and welcome to this DNB OSCE session part 1. My name is Dr. Jhanvi and today we will be discussing some of the previously asked OSCE questions in the DNB exam. Now, the reason I have actually clubbed all of these sessions together, starting from today, we are going to have a DNB OSCE session every day for the next 1 week. This is specifically because your upcoming exams are scheduled for 15th of Feb and also 9th of March. So there are 2 dates that have been given for the OSCE exams, for the practical exams. And I expect that all of you all must be scampering to different places trying to find out the OSCE questions. So I thought I would make your life easier by just putting all of them in one place over here today. So we have almost about 100 to 130 OSCE questions, and we will be discussing them slowly over this 1 week. The timing is going to be the same every day, 8:30 p.m. And tomorrow we are going to do it at 9:30 p.m. Just tomorrow will be 9:30. The rest of the days will be 8:30. So let's start off with the first question. Just remember, whenever you get the OSCE, make sure to give very specific answers. Do not write essays because you're not going to get time to complete writing the answers for the OSCEs. And also they are not going to give you marks for writing long answers. Okay, the marks will be given for writing precise answers, not long answers. So one of the most importantly asked OSCEs is about biomedical waste management. They tend to ask this in each and every exam, and almost it has come thrice before. Now all these OSCE questions that I am putting out over here are the OSCEs that have been asked previously in the exams, and the students have given these as recalls. So it's not something that I've made up on my own, but it is actually what DNB asks. So the first one is, name any items discarded in red, yellow, white, and blue colored containers. So we all go to the OT, we all use many things, and when it comes times to discard things like our gloves or vials or ampules, we will be just throwing them around as we wish. But unfortunately, DNB wants you to know where is the correct place of disposal of different things in the OT. So if you actually do it properly, you would know that in all of these containers, what are the things that we throw? And I'm going to give you a few mnemonics to remember this. So what do we throw in red, yellow, white, and blue colored containers? Now, if I think of what I do in the OT, first of all, it's very easy to remember that white containers are the puncture-proof containers. Okay. So in white puncture-proof containers, what do we throw? We generally throw any kind of sharps, any kind of sharp waste. What do we throw in blue colored containers? You must have seen that there are plastic containers with a blue bag in them. And we generally tend to throw any broken ampules or any vials, anything made up of glass is thrown in these blue colored containers. Okay. Now comes red and yellow. Out of this, yellow is easy to remember because I don't know if you remember in PSM, we used to always say human anatomical waste. So it could be tissue waste, or it could be something like placenta, which you throw after LSCS. All of these human anatomical waste is thrown in yellow. And in the red containers, we tend to throw any kind of plastic, rubber, tubings, infectious waste. Okay, now it is a little bit too much to remember all of these. So I'll give you easy mnemonics to remember them. So let's have a look at this. The first thing you can see over here is that paper is burning. Okay. So if you remember what you throw in a black container. So black container or a black bag will always have paper in it. Okay. Any kind of paper. Or the second thing that you can throw in it is cytotoxic waste. Okay. Paper or cytotoxic waste. Now how to remember? Just remember when paper burns, it turns black in color. Okay, so you're burning paper, you're throwing in the black bag. So that is an easy way to remember what you throw in the black bag. Okay, now next is for the red bag. What is the mnemonic for the red bag? Just remember a red colored parrot. Why have I written a red colored parrot? There is a reason for this. If you look at parrot, P, R, and T, just mark over here. Okay, P for plastic, R for rubber, and also the second R can be for red color bag. Okay. And T is for tubings. So any kind of plastic, rubber tubings, and one more thing, whenever you have used gloves, whenever you have gloves that contain infected waste on them, so those infected gloves or used gloves are always thrown in the red bag. Okay. Now, if I ask you Foley's catheter is thrown in which bag? So if they ask you in the exam simply Foley's catheter is thrown in which color bag? So Foley's catheter is made up of rubber. So you know that it can be thrown in the red bag. If I ask you IV set is thrown in which bag, or blood set is thrown in which bag? Again, they are tubings, so they are thrown in the red bag. Okay. So this is how you remember what is thrown in the black bag, what is thrown in the red bag. These are the two mnemonics. Now the third mnemonic is for the blue bag. Now the blue bag is always like a bag which is in a plastic container. But remember, to see the blue sky from your room, you need to have a glass ceiling. Okay, so you can remember this pictorial mnemonic only. So you can see that there is the blue sky over here, which you can see if you have a glass ceiling. Now, why have I given you this mnemonic? If you want to remember what is there in the blue bag, you need to just remember that anything made up of glass. What is made up of glass? Vials, all of these are made up of glass. So they are thrown in the blue bag. Okay. And the next thing that you have to remember is what do we throw in the white container? Now, honestly, if you are doing it properly in your hospital, you don't have to remember this mnemonic wise. But for many hospitals, we actually don't follow the biomedical waste guidelines and everything is just mixed. So this makes it easy to remember it for the exam. So for white puncture-proof container, we always throw sharps. So to remember that, you can actually just remember the picture of this tone t-shirt, tone white t-shirt. So maybe there were a lot of sharps or needles with which you have toned this white colored t-shirt. And that is how you can remember that sharps are thrown in a white puncture-proof container. Okay. So these are a few mnemonics that will help you remember what waste is thrown in which colored bags in the biomedical waste management guidelines. All right. So that's done with the first question. Second is, what are the 5 recommended methods for biomedical waste management? So any idea, can anyone answer? We have a lot of people over here, Renuka, Pooja, Medico, iPhone. I'm sure that's not your name, but what are the methods for managing the waste? Now, before...
Incineration.
Yes, very good. Anything else?
Incineration,
Soiling,
segregation.
autoclaving.
Segregation, yeah.
Okay, so segregation is not a method for managing the waste. It is just what are the steps that you do after you collect the waste. Okay, so these are the steps that you do after you collect the waste. First, you segregate all of them in one place. Okay, then you handle it and you transport it and then you treat it and then you dispose it. When they're asking you steps of biomedical waste management, they mean like what do you do with the waste once it goes to the dumping ground. Okay, so you can incinerate it, that is
Autoclaving, ma'am.
autoclave it, that is correct. Anything else?
कैसे
Use
महान
any chemicals?
Yes, ma'am.
Which one?
EDTA, ma'am.
EDTA, no. Okay, so I'm going to cut it short. So these are the treatment processes with which we treat the biomedical waste. Okay, the first one is alkaline hydrolysis. So here we use alkalis like sodium hydroxide or potassium hydroxide. And what they do is they can't kill the bacteria. They are not bactericidal, but these alkali will actually make the bacteria inactive. So they are bacteriostatic. Okay, so you have sodium hydroxide, potassium hydroxide, which will hydrolyze the walls of the bacteria and they'll make it bacteriostatic. Okay. Then we have any chemicals that you all know of, very simple. COVID ke time pe we used to use a lot of those and questions were also asked on them.
Sodium hypochlorite.
Yeah, alcohols, a sodium hypochlorite, glutaraldehyde, all of these chemicals are used to inactivate the microorganisms. Pyrolysis, heat, microwave are all forms of heat only. Microwave is a form of radiation. And steam autoclaving. What are we using in steam autoclaving? We are using superheated steam to kill the bacteria. Superheated steam to kill the bacteria. Okay, so I'm not going into the details of how do you do it, because for OSCEs, you don't need to know in the details. They are not going to make you write questions and answers. You just need to write it point-wise. Okay, so these are the treatment processes for biomedical waste. All right, then the next is, what is the ideal disinfectant for surface of trolleys or bins infected with COVID-19? And you have to give me the exact chemical along with its concentration also. Actually, this OSCE was asked during COVID, so that's why it's like so COVID centered. But biomedical waste management has been asked at least thrice before. Okay.
Glutaraldehyde.
No, not blue.
Ma'am, bin to yellow bin, ma'am.
No. Okay, so it is 1% sodium hypochlorite, which is used to clean the surface of trolleys or bins infected with COVID-19. Okay, it is not glutaraldehyde, it is not any other option that you all spoke about, but it is 1% sodium hypochlorite. Okay, and again, you need to know what is the color of the container used for discarding COVID-19 PPE kits. Now, I hope you all know that we did not throw the entire PPE kit in one particular container. You were supposed to throw different parts of the PPE in different colored containers. So actually the major two containers were the red container and the yellow container. So anyone knows what is thrown in red, what is thrown in yellow? Any idea? Or you just remove the whole thing, throw it, dump it wherever and leave, go home once your shift is over.
Gloves in red and PP kit in yellow, ma'am.
Yes, absolutely correct. So if you look over here, your N95 mask, head cover and shoe cover was thrown in the yellow bag. Okay. Your used PPE kit, the entire PPE kit, hazmat suit, gloves, face shield and goggles were thrown in red. Now again, this becomes really difficult to remember what is thrown in red bag, what is thrown in yellow bag. So you think of this in a very common sense way. Whatever part of the PPE touches the patient or has direct contact with the patient's, say secretions or saliva or whatever the patient coughs out, that will be thrown in the red bag, the more infectious bag. Okay. So for example, used PP, the entire PP kit will touch the patient when you're trying to make them sit or move. Gloves, you're touching the patient, so that is in direct contact with the patient. Face shield and goggles, when the patient coughs, his secretions or droplets can fall on the face shield or goggles. So all of that is thrown in the red bag. Whatever is not directly in contact with the patient, for example, head cover or shoe cover or N95 mask was always worn inside the shield. So that is thrown in the yellow bag. Okay. So that is a way to remember what is thrown in the red bag, what is thrown in the yellow bag as part of the PPE kit. Honestly, I don't think this question should come back again now. So the second part of this question that they asked all about COVID, I don't think they will ask again now, but definitely the first two parts of the question are something that can be asked again. Okay. And if you tell me what OSCE should you revise before going to the exam, then definitely you should be revising your biomedical waste management. That is one of the most important OSCEs to remember. Just 1 second. The minute you guys joined, this PPT just stops. Okay, now we'll move on to our next question. Okay, now this is more anesthesia related and it is like a case scenario, which is very interesting. So this was asked in the exam. Again, many of you all have joined later. I just want to claim that these are not man-ghadat DNB OSCEs. I have not made them on my own. These are the ones that have come in your exam before and your seniors have given the questions. Okay, so a 70-year-old patient presented to casualty with severe airway obstruction with desaturation. Intubation was attempted, large mass was seen in the laryngopharynx. Glottis could not be visualized. What is the plan of management? So this is a sort of the picture that came and you can see that there is a large mass which is completely obstructing the larynx. You cannot see the glottic opening. What will be your plan of management? So can anyone tell me what will be your plan of management? And remember, patient is not in the OT. Please read the question carefully. Patient is probably in the casualty or emergency services. Yes, the patient is in the casualty. Okay, they have called you because you're the intubation expert. What will you do? Anyone?
Ma'am, needle cricotherotomy.
Okay, so the best thing to answer would be you will do a front of neck access. Okay, front of neck
Yes,
access.
ma'am.
What comes in front of neck access? Can you give me the two things that come in that?
Ma'am, needle cricotherotomy and Tracheostomy.
Okay, so when I say two things, it will be cricothyroidotomy and tracheostomy. This is how I will write my answer in the exam. In cricothyroidotomy, you have two. You have needle cricothyroidotomy, in which you can do it using a whiteboard needle, or you have a scalpel bougie tube technique. Anyone knows about the scalpel bougie tube technique? In that, you make a long vertical cut with the scalpel, dissect the tissues. Wherever you find the trachea, take a cut, put a bougie, and over the bougie, railroad a small tube, 6 or 6.5 number tube. Okay, so that is the scalpel bougie tube technique of cricothyroidotomy. Now, if I have to give one answer that what will be my way of securing the airway, I will go for a more secure version of FONA. The more secure version of FONA will be tracheostomy. I will not go for needle cricothyroidotomy because it will not really give enough oxygenation to my patient. Okay. So tracheostomy will be my answer, but this is how I will write. Plan of management is front of neck access, cricothyroidotomy and tracheostomy are the options, and preferred airway management will be tracheostomy. Okay. All right. Now, after securing the airway, the patient has respiratory distress with bilateral creps. What do you think is the diagnosis?
Ma'am, laryngospasm.
Why would he go into laryngospasm, but you have secured the airway, na, niche? Okay. There is a mass which is obstructing the larynx. So, for a long time, the patient is breathing with against a
Negative pressure pulmonary edema.
Yes, ma'am.
Very good. So he's almost breathing against a closed glottis. Okay. So the answer over here is negative pressure pulmonary edema. Okay. And when you say laryngospasm will not really explain why the patient has creps. All right. There are only a couple of reasons why you get creps. One will be ARDS, one will be pulmonary edema. Pulmonary edema can be many causes, cardiogenic, neurogenic, but none of these actually fall into place in the condition they have given over here. Now, what happens in negative pressure pulmonary edema? This is my alveoli and this is my capillary, which is below the alveoli. Okay. Now, when I'm breathing against an obstructed airway, what I'm doing is I'm generating a lot of negative pressure. I'm breathing like this. Okay. So when I'm generating a lot of negative pressure, this negative pressure gets transmitted from the alveoli. And what it does is it pulls the contents of the capillaries. Okay. What contents of the capillaries? The plasma from the capillaries, pulmonary capillaries, will actually start entering into the alveoli. And this is how the alveoli gets filled with plasma or with fluid. And when you know that whenever there is fluid in the alveoli, this is called as pulmonary edema. Okay. So because of the extreme negative pressure that is generated while breathing against an obstruction, whatever is there in the capillaries gets pulled into the alveoli. Okay. So this is called as negative pressure pulmonary edema. So now very simple thing. If I have negative pressure pulmonary edema, the first thing I'll do is relieve the obstruction. I have already done that by tracheostomy. What is the second thing? If I want to push this plasma back into its place, back into the capillaries, then how do I treat my patient? Because they have asked over here, how will you manage the case? Because of negative pressure, it is getting sucked into the alveoli. So what can I do to push it back into the
Positive
capillaries?
pressure ventilation. ma'am.
Positive pressure ventilation.
Very good. So put the patient on mechanical ventilation with positive pressure. Anything else that will dry out the plasma?
Diuretics.
Diuretics.
So that is how we will manage the case. Okay, diuretics and positive pressure ventilation. And of course, always as an anesthetist, the first thing you should think of is oxygen levels. So 100% oxygen in every case. Okay. Now, one more thing that they have asked here is, what are the 2 point of care investigations to confirm your diagnosis? Point of care means bedside. You don't have to shift the patient to any place to get the investigation.
Bedside ultrasound, ma'am.
Ultrasound.
Very good. So you can do an ultrasound. Now you have to also tell me, I'm not, maybe DNB is not asking you over here, but you have to tell me what will be your finding in ultrasound on pulmonary edema. Please remember, study
Ma'am, bat wing
ultrasound and go
appearance.
for your exam.
B lines.
Very good, Renuka.
B lines more than 3 lines, ma'am.
Yes. Now, B lines you can see normally also. You have to tell me how many B lines.
More than 3 lines, ma'am.
More
Very
than 3.
Okay, so these are B lines. This is a picture of B lines. How do you identify B lines? You can see this, the shiny part that is there on top of the screen is your pleura. Starting from the pleura, you will see vertical lines going. Okay. So if you can see more than 3 vertical lines, then this is abnormal number of B lines. And this has few implications. Can you tell me in which condition do we see B lines? More than 3? Normally, you can see less than 3. But if you're seeing more than 3, then what could be the conditions? One, you can tell me from what we just discussed.
Pulmonary edema, pneumonia.
Pulmonary
Pleural
edema
effusion.
due to any cause. Okay. Anything this. Then pleural
Sorry.
effusion. Okay.
Yes.
Anything else?
Pneumonia.
Pneumothorax.
ILD. No, pneumothorax will show you absent lung slide. Okay. No B lines. Absent lung slide. Okay. So these are the causes of abnormal B lines. All right. So this is one of the point of care investigations. What is the other point of care investigation you will see?
Ma'am, chest X-ray, bedside chest X-ray. Ma'am.
Yes, very good. So you can do a portable chest X-ray. What is the sign that you see?
Bat wing appearance.
Batwing appearance.
So bat wing appearance is seen whenever you have pulmonary edema. Okay, so this is done. Okay. Now, next is, so this is a slide. I would recommend that you guys can actually take a picture of this slide. So it gives you a USG lung appearance. It is actually the lung ultrasound. What is the appearance and what is the diagnosis? So I'll keep it on for 2 minutes. You guys can take a picture and you can revise from this. We don't have enough time to go through the entire slide, but lung ultrasound has been asked. Like they don't ask. They will give you different pictures and ask you diagnose the lung ultrasound. Okay, so they don't really ask the entire thing like a table, like how I've put it, but I've just made it easy for you all. Okay, everyone is done. All right. Okay, we move on to our next question. A morbidly obese patient is posted for surgery under general anesthesia. This view was obtained during airway examination. Identify the test.
CL grading, ma'am.
This is not
Modified Malam-Patti.
Sorry,
Yes.
And
So this is
without
Malampatti
phonation.
classification. Now you have to tell me, is it Malampatti scoring, Malampatti classification, Malampatti grading? Because in the exam, everyone will use all different words. What is the exact word?
Classification. Malam-Patti or
It is
grade, no?
Malampatti grading. Okay. Is this modified Malampatti grading or is it Malampatti grading?
Modified.
How do you know that? Okay, from this picture, you can't see it whether it is modified or not. What is the difference between Malampatti and modified Malampatti?
Modified epiglottis is seen, like the grade 0 is added in the modified,
So
no?
modified Malampatti gave you grade 4. Before the modification by Samson and Young, we had only grade 1, 2, and 3. Grade 4 was added by Samson and Young. Okay, so that is called as modified Malampatti grading by Samson and Young. Okay, now you have to tell me how do you grade this view? Is it 1, 2, 3, 4? And then, yes, of course, after that, recently we've also had one more modification where we have added class 0 Malampatti, where you can directly see the epiglottis. So what are the structures that you can see over here?
Base of the uvula.
Okay.
Base of the uvula.
Yes.
Hard palate.
Okay, so you can actually see soft palate and you can see the hard palate. Okay. So soft palate and hard palate is same. Who is this? Someone needs to mute me. Okay. So you can see the soft palate and hard palate. So this is the Malampatti grading. If you see, let's go to all the things. So this is the entire uvula. This is the tip of the uvula. This is the base of the uvula. You can see the entire tonsillar pillars. You can see the soft palate over here. Okay. And you can see the hard palate. So this is Malampatti class 1. Malampatti class 2, you will nicely see the base of the uvula and you will not see the tip of the uvula. Okay. So the tip is not seen, but you can see the entire base of the uvula along with the soft palate and the hard palate, but you cannot see the tonsillar pillars also. So tip and tonsillar pillars. 2 T's are not seen in Malampati class 2. That's how you can remember 2. You will not see tip of uvula and you can't see tonsillar pillars. Okay. Now Malampati class 3 is something that came in your exam. So this is what you see. Actually, I would say that you just see the soft palate. I wouldn't even say that you see the entire base of the uvula. So you see the entire soft palate which lasts till here, and then you see the hard palate. And in class 4, we see the hard palate only. Okay. So this is Malampati grading. And the view over here will be CL grade 3.